I guess I had a question for Stuart. So I kind of, yesterday, Jordan made a comment about how people are having like 5 antibody tests in Canada before they're actually getting engaged in HCV RNA testing. And so if that's actually the case, and if that's the case elsewhere, then really is it a more cost-effective strategy to be doing the antibody testing, but rather to just be going right to RNA? And then do you think that's what we need to use to really lobby for alternative diagnostic testing strategies?
I think it's a great point that we need to make a financial case for people to understand this, and that's a great example of this. I think, there are 2 costs there. One is the cost of all that testing, also all the staff and infrastructure costs of having those people get those things done and nothing happens. The risk of, erroneous testing, shipping of specimens far from people, of course, in tubes runs the risk if they're not well labeled. And then finally, there's this context disruption problem that when I see a patient, I need to read something about them, figure out who they are, introduce myself, we develop a relationship. They leave, they come back. I have to remember who this person is, however long ago it was that this was done, if I'm even the same person who sent the first test. All of this friction in the system is a cost. And so we need to quantify that. I'm not the person who can do that, but there are people who can, but I agree completely.
Can I add a comment to that? So, and this is a real world example. Is the mic on?
Yeah.
Okay. So that's really interesting about going RNA first and then the antibody, because I definitely believe there's examples where that should be implemented. So the real world example is we do all the viral STI testing for a PHAC, and that includes injection drug use, which is probably the highest number. So it didn't matter which site across Canada, if it was a known injection. We started at 50% prevalence and then worked up. So if you're going to go with those kind of numbers, it begs the question, why are you doing antibody, right? Just go straight to RNA. And I completely agree. The reason we start with antibody followed by molecular or whatever is because of cost and actually throughput as well. But in that particular case, it could be argued it was a waste of time for us to do. So perhaps maybe similar to syphilis, where we do a reverse algorithm, right? Start with the RNA, perhaps maybe the negatives, then do the antibody. I think it would be a cheaper way, ultimately, of doing that. Yeah.
We're going to alternate microphones. Sorry.
Thank you. Wendy Wobesser, currently living in the land of the Anishinaabe and Haudenosaunee peoples, sometimes referred to as Upper Canada. I'll leave it to your imagination. But thank you for the talks. I was actually going to follow up, or I was thinking about a talk like this. So in the province I'm in, and health is a provincial responsibility, so we can disrupt at the federal level, but how do we actually bring the disruption to the provincial level where, as Jordan referred to yesterday, it's at best inefficient, at worst anarchic screening program in the province of Ontario. And under current leadership, I think without really having some very ironclad something to enforce change is needed. And I think human rights has to come into it. I also come from a TB, a field. Thank you for putting it up there, John, in your corner. And I look forward to advancements in our diagnostics, given that our current diagnostic used for LTBI has a specificity in most situations of 30%. So my question is, I guess, so how do you, with disruptive, so we know that these diagnostics are better. We let economics trump human rights, and then we're in a federal system. So I guess maybe if you could just speak to that generally, I don't know, both of you.
Geez, Wendy, there's a lot there. So what I'm going to start, and then we'll see how it goes from there, just in terms of personal experience. Although the slides look like it was an easy go, it's not an easy go. And we still continue to see barriers depending on what the province is. I think the idea here is quite often it's like calling the Canada Revenue Service, right? You have a question. If you don't like the answer on the first one, you just go and call the second guy, right? And you pick the one you want. So in terms of trying to get buy-in, let's say at the provincial level, you just have to keep going and keep going. So as I showed in the example with Saskatchewan and Ontario, and I don't know what happened with Alberta, but they're full on without even one dry blood spot test. But even in my province of Manitoba, we are starting to see where the buy-in is happening. Now, one comment I will say, in practically every location, it's been people from community that have driven this effort. And essentially, and I'll go out and say it, it is them who is essentially embarrassing, off record, pushing or driving public health to do something about it. So it's in response to that. So I don't know if that addresses your question, but the fact that we're actually already seeing implementation at that structural level gives me hope that this is just good. A forest fire starts with a spark, right? So I think that spark is started. We just need to continue the momentum.
And parenthetically, PEPFAR got a big start from a Bush president. So it can come from anywhere.
Sam Lee, Calgary. First of all, John, we're pumped. We're really, really excited about this DSP program rolling out in Alberta. Especially, I lead a Project Echo type telehealth HCV delivery to remote Indigenous communities. So that thing will work just perfectly, especially the drone thing. I think that's got great potential. I have a quick question, perhaps for either speaker. Occasionally we get these twilight zone HCV RNA results, detectable but unquantifiable. They're between 15 to 2 or 3. What are those? Are they true negatives? Are they really low-level viremia? What are they?
Well, it's all about context, right? So is this a person being screened or a person on treatment?
After treatment.
And it's immediately after treatment or long after treatment?
At the week 12, or sometimes at the end of treatment.
Yeah, so those have not, if you look at the study, including Jordan's that I presented, there are people who are quantifiable or detectable, and even sometimes low-level quantifiable at the end of treatment or even at the 12-week after, who ultimately have an SVR. So it's really, those need to be followed. But if we detune the assay, we might not even trouble those people. So if we had a cheaper assay and we could do it more often, then we could just say, you know what, we really should be keeping on testing you, partly because you may resume risk behaviors, or you may not even know that your risk is something that a doctor did in an office. So we still have a fair amount of iatrogenic transmission, and I think we just need to have people tested more often for virus and not with such a sensitive assay. I think, lots of studies showed that low-level viremia at the very end of treatment or shortly after is often cleared, and we don't understand it. Dr. Bartenschlager will tell us where that's coming from someday.
Jason Grebley from Kirby Institute, UNSW. Hey, great talks, both of you. Thank you very much. I guess it's a sort of a two-part question that are sort of related, and I guess it relates to barriers to getting these new technologies into clinical practice. And so for Stuart, I'm sort of keen. You kind of mentioned it, and yes, the guidelines could be revised, and that could help things to kind of get companies to invest and drive things forward in terms of innovation. But what do you think sort of researchers and clinicians, people in the room, can be doing to sort of drive forward this agenda to get companies interested? We hear this argument, and they're not looking at the numbers needed to test, they're looking at the numbers of people infected. So how do we get the companies to sort of drive forward innovation? That's the one part for Stuart. And then in terms of sort of the dry blood spot testing component, another problem with the manufacturers is they're not, making a claim for DBS. And I know there's work with Foundation of Innovative New Diagnostics to get this study done so that they can have the data to make those claims. But from John's perspective, because an argument that labs often push back at, or even clinical, we can't use this, it's not approved in our setting, it needs to be Health Canada approved. You can't do that without the data, which is a big study. So how do you drive things forward within countries in the absence of an indication? And how have you done that with the work in Canada? I guess it's easy because you're at the public lab, but what about provincial labs?
Okay. Thanks for that, Jason. So the best way I can address that is the following. that is pediatric testing for babies born to HIV positive moms. So everybody knows you can't use serology because of the maternal antibody transfer. So you have to go to molecular means. Since the epidemic started, there has never been an approved molecular test for HIV, whether it be for adults or babies. So does that mean that we don't have the ability to ever test for babies born to HIV positive moms? No, of course not. Any quality management system will allow you to use a lab developed test like we have as a reference lab. That also includes the provincial labs as well. And there's some that have done really good validation. So that's the way out. Well, I shouldn't say the way out. That's how you address where, the company refuses to license or put a claim, whether it be medical devices, FDA or CE. That's how you get you address that. The second part, and specific for the dry blood spots, although we see this as a very promising way of increasing access, I think that will be a challenge. And because what you need there is at some point in the future, when we start to get to like tens of thousands, and it starts becoming normalized, in fact, it stops being interesting for us. We need to move on to something, what's the next innovative thing we need to be part of? So at that point, it has to be transferred to the provinces. First thing the provinces are going to ask is, let's say the Abbott architect is, Abbott, do you have a dry blood spot protocol for that? Or it could be any other assay. So if they say no, or somebody else has one, then they're going to go to that. Now, that's the challenge, and that's the part we don't have as much control. Now, one thing I can say, however, is that there are companies, especially on the molecular level, like as an example, Hologic. I think we're just waiting for them to come out with a CE-marked hepatitis C. And we actually we got the first 2 Panthers in Canada because that's where we're going, is because of the random access stuff. But anyway, that's the part that's not as easy to control, is convincing. And it doesn't matter, forget about dry blood spots, even really good tests like line immunoassays, we've tried for the last 15 years, and it tends to be based on market size, right?
And just very briefly, everybody has a voice, and we don't have enough experts using it. So whether it's in social media, pushing back on irrational things, pushing for rational things, and then we can ignore Wikipedia at our risk. It's the second most read medical site after PubMed, and it's unemployed PhD deathmatch. But you guys can get rationality into content there as well, which is what people look at.
We'll take just one more quick question, I think, because we're running on time. I know there's so much interest, and then hopefully at the end we might still have some more time.
My name's Mel Krasden. I'm one of those laboratorians. So
that's why I let him go first.
So one thing that I think is important is a recent publication by Morgan Friedman has pegged around 1,000 IUs per ml as being able to detect about 97%. And it may be even less as in certain women and younger people. So I think, and with dried blood spots, I think we need a transparency. And that transparency is, it's better to have a test, even if the test is slightly inferior. But the community that gets that test needs to have solid data to know what the sensitivity is in the real world. And I think that is an important component, and it gets lost in this dialogue.
Yeah.
I certainly don't disagree.
So I definitely agree with you, Mel and Jordan. So what's comforting is when I saw Dr. Ray's in terms of the 1,000 copy per mil cutoff, when we were doing our validation for both HIV and hepatitis C, that's exactly the cutoff we had. We know that dry blood spots, just based on the amount of blood that goes on the spot, is not going to be as sensitive as 1 mil of pure plasma. But at 1,000 copies, at that 90, is there a usefulness to that? And every clinician we've spoken with, and I think you would agree as well, is of course it is. I mean, the question here that you would ask is, would a physician actually change a drug regimen based on an inability, or let's say even if you were able to quantitate off dried blood spots, let's say somebody was 300 or 400 based on, and somebody was LOD before, would they truly change their regimen? Everyone we've spoken with says probably not.
I think you're missing the point. The point of the matter is that they need to know that if you're getting the test, you might
not
miss
perfect.
3 to 5%.
yeah, sure.
That's the point.
Yeah.
It's not whether
Yeah.
or not
Yeah.
you shouldn't have access to
Yeah.
it.
Yeah.
It's actually the exact argument we've had with the public health lab in Ontario is them saying
Right.
that if they do a DBS
Yeah.
test and it's negative,
Yeah.
that they're required to inform the person that they still need a phlebotomy-based test to
Yeah.
really exclude HCV.
Yeah.
And obviously, if you do that, you pretty much get rid of any benefits of
Yeah.
DBS.
I just think it's worth saying, though, that as a clinician, I think laboratorians overestimate how confident we are in any of their results. None of them are 100%. So we always look at that specimen and say, was that the right person's specimen? Did it get transported properly?
Yeah. And Mel, just to address your question, now that I understand, in fact, that's been a more challenging discussion. It's actually with the laboratorians. When we do knowledge translation, let's say with community, we have to explain that it is not the perfect test, but in the absence of the perfect test, is this acceptable? And it's been yes, unanimously yes. It's the laboratorians like you and me that are the hard nuggets.
Thank you. Thank you, doctor.